As you can see here, I told you the spinal cord's growth stops whereas vertebral column keeps growing. That's the reason you see spinal cord is ending at the level of L1. It extends from C1 to L1. So, okay. Positional change, all these are not required, but don't trouble yourself. I'll go with the things which are important. This is important. Basically, the spinal meninges, we have three meninges, isn't it? What are those? The outermost is dura mater, middle is arachnoid mater, and the inside is pia mater. Okay? Dura, arachnoid, and pia. So, three meningeal coverings. What we usually see around the brain, same meningeal coverings we also see around the spinal cord. Okay? So, this is the cut section of spinal cord. You can see, and you can see the three coverings also. The outermost covering is the dura mater, and middle covering is this black line arachnoid matter. Innermost covering what we have is pia mater. The space below the arachnoid matter is subarachnoid space. Space below the dura mater is subdural space. Okay. Then see, the pia mater is actually like thin when you compare with the other three layers. It is highly vascular membrane. It continues below the spinal cord as phylum terminale. This is the phylum terminale, red in color. Okay, the space between the pia mater, I already told you we have that is the subarachnoid space, which is filled with cerebrospinal fluid. Okay, so at the level of this terminal part of the spinal cord, you will see there is enlarged space where lot of CSF is accommodated, which you call as subarachnoid space. Subarachnoid actually, cistern means the space, that means elongated area where you have lot of CSF. So this area is showing the subarachnoid space around the phylum terminal. It becomes roomy and it has a lot of CSF. Hence, this area is called as lumbar cistern. Okay, lumbar cistern. So, generally, we do lumbar puncture here only, like we just inject the needle between L3 and L4 and see that we collect the CSF. Okay. Now, what are the modifications of pia mater? The modifications of pia mater are four. First thing we have is phylum terminal, this one, red line. Okay, on either side, that is ligamentum denticulata, ligamentum splendum, and we have subarachnoid septum. So, among all those, the most important topic we have is phylum terminal. It is delicate white thread-like structure when you see in the correct spinal cord, which is shown in red line here. So this cone-shaped part of spinal cord, terminal end part of spinal cord is actually called as conus medullaris. Conus medullaris. From the tip of conus medullaris, you are finding the phylum terminale is coming. And we see the part of the phylum terminale which is covered by dura mater. This is violet area which is covered by dura mater. This is actually called as phylum terminale internum. It is inside dura mater. That's why phylum terminale internum. And the part of the pia mater which is outside the dura as a single line, it has no covering. You call it as phylum terminale externum. So overall, the length of phylum terminale is 20 centimeters. 15 centimeters will be inside. 5 centimeters will be outside. 15 plus 5 makes 20. So internum and externum respectively. Okay. Second modification of pia mater, we have subarachnoid septum. No, so subarachnoid septum is a small, like extension of the pia mater. That is not so important, but this is very very important. We have seen in our previous papers also. I've used internet to show this answer. Ligamentum denticulatum. So you are finding two transparency. This one, this one. This is spinal nerve. Don't get confused. This is spinal nerve. In between spinal nerves, you are finding a triangular expansion. These triangular expansions are nothing but pial extensions, pia mater extensions. So this is nothing but ligamentum denticulatum, singular. Plural is ligamenta denticulata. So true two transparent ribbon-like thickened bands of pia matter which will be extending on either side of the spinal cord. They will be running between the anterior and posterior nerve rootlets. Overall, we have 21 tooth-like, if you just count, 21 pairs will be there throughout the spinal cord. 21 tooth-like processes we will have, that is ligamentum denticulatum. Now, when you see the external features of spinal cord, so it has anterior median fissure, posterior median sulcus. These are the spinal nerves. This is anterior horn. This side is posterior because we have this dorsal root ganglion. This is the spinal nerve. Spinal nerve. Okay. So this cut section we have seen in physiology also. This is anterior median fissure, posterior median sulcus. These are the anterior horns, these are the posterior horns, these are intermediate horns. This is central canal. This is all white matter where we have ascending and descending tracts, if you remember physiology picture. How many pairs of spinal nerves do we have? 31 pairs of spinal nerves we have which are emerging from either side of the spinal cord. So we need to number them. Cervical, green in color, if you count 1, 2, 3, 4, they take part in the formation of our popular brachial plexus. First four are cervical plexus, lower are the brachial plexus. So we have altogether, if you count, 8 pairs of cervical, 12 pairs of thoracic, blue in color, 5 pairs of sacral, violet in color, 5 pairs of lumbar, red in color, and 1 coccygeal. So if you make a grand total of it, it will be how many? 31 pairs of spinal nerves we see coming from spinal cord. Okay, so again the same picture we have. Always wherever you have this ganglion, you have to identify this as posterior horn. Posterior horn only we will have dorsal root ganglion. Okay, so sometimes there is a question like in like spinal cord enlargements, like cervical enlargement and lumbar enlargement question may come. So cervical enlargement is the enlargement which you see in the neck region, which is extending from C3 to T2. Okay, so this part of the spinal cord is enlarged so as to give origin to the brachial plexus, because brachial plexus has to supply upper limb. Similarly, the lumbar region is also little enlarged, you call it as lumbar enlargement. It is extending from L1 to S3, quite big enlargement. So this is enlargement, it is so enlarged because it has to give nerve supply to lower limbs, that is lumbar plexus. Okay, so these are the two enlargements we have in the spinal cord. Okay, now this is also a short note, cauda equina. We know this is the cone shaped area, the terminal part of spinal cord, conus medullaris. From here, bunch of nerves like ponytail, horse ponytail will be there, no? So like that you will see bunch of nerves are coming out because they have to come out through respective intervertebral foramina. So this bundle of nerves is actually called as cauda equina. Okay, so that is. These are all cut sections of spinal cords at various levels. These are the nuclei beta, which I told you in physiology also. Okay, so this is we have anterior horn and then posterior horn. Okay, so various nuclei. Nuclei actually they are not important in anatomy. Tracts are also not important in anatomy. So you have asked me blood supply, right? Of course, blood supply is important in anatomy. So we see like blood supply of spinal cord comes from one anterior spinal artery. You can see this is in midline, and two posterior spinal arteries. This is anterior view. You are seeing from front. This is posterior view. We are seeing from behind. So two arteries you are seeing, those are the two posterior spinal arteries. Apart from that, you can see so many arteries are seen. So throughout the vertebral column. So these branches are actually called as segmental arteries. Okay. So all these arteries, they form extensive network inside the spinal cord. Okay. To split these, like we have one anterior spinal, posterior spinal. Then there is a spinal branch coming from the first intercostal artery. Okay, then we will see one spinal branch coming from 11th intercostal artery. This is 11th one. Then branches of vertebra. This is our vertebral artery, which goes inside the skull bone to form, what is that we have at the base? Circle of Willis. Okay, this is the artery which goes inside, vertebral artery. From there also you will see the blood supply to the spinal cord comes. Deep cervical arteries, intercostal arteries, lumbar arteries, all these arteries will give blood supply to the spinal cord. So when you talk about the anterior spinal artery, it is present throughout the anterior median fissure, this whole thing. Okay, so that is the posterior spinal arteries. They are derived basically from this vertebral. How many? They are two in number. Okay, so from the foramen magnum you can see they are descending almost up to the level of like sacrum, coccyx. Till that you will see blood supply is there. So like that, if you just count them, we have 21 pairs of segmental arteries. Segment wise, if you check, we had ligamentum denticulata also 21 pairs. Similarly, the arteries which are entering inside from either side, they are also 21 pairs which are supplying the spinal cord. Okay, one of the artery will be quite big, which supplies the spinal cord. You call it as artery of Adam Quiz. Okay, so that is basically it may arise from the first and 11th intercostal arteries. Okay, all these are not required. Now, once you know the arterial supply, we should know the venous drainage. Correspondingly, we will have the spinal veins also. Okay, so see how many, like we have two median longitudinal veins, we have two anterolateral veins, two posterolateral veins. So all these, how many? Six set of veins are there. Two median longitudinal, two anterolateral, two posterolateral. There is good picture given in textbook, in fact, in the cut section. You will see six veins. All these six veins, they will be draining into this vein. So this vein is internal vertebral venous plexus, okay, which goes and drains into the brain. Into which vein of brain? Basilar venous plexus. Okay, these are the tracts what we have seen in physiology. In anatomy also, suddenly if it is asked, you need not panic. You can write the same story because we have same tracts: anterior spinothalamic tracts, lateral spinothalamic tract, and we have corticospinal tracts, nothing but pyramidal tracts. Okay, those are all. So that is all about that beta. So when you ask me the ganglions, right? Now, when you see in the hand, now what are these bones we have? These are metacarpal bones, right? So how many metacarpals we have? One, two, three, four, five.
Oh,
So between the metacarpal bones, whatever earthworm-like muscles we have, bipinnate muscles we have, they are basically called as interosseous muscles. And counting of interosseous is always from the thumb side. This is the thumb. So when you see from the dorsum of the hand, when you observe the interossea, you call them as dorsal interossea. Okay. So how many dorsal interossea are there? One, two, three, four. When you talk about first dorsal interossea, you are finding it is coming from the medial aspect of the first metacarpal and lateral aspect of the second metacarpal. And this is bipinnate muscle. That means it is something like two sides. If it comes, you call it as bipinnate. And it comes and it is getting inserted at the base of the proximal phalanx of the index finger. This is the base of the proximal phalanx of the index finger. If you look at the picture, you yourself will write better. Now, when you describe second interossea, it is coming, see, towards the little finger side is medial and towards the thumb side is lateral. Or you can write adjacent sides to avoid confusion. Adjacent sides of second and third metacarpals. The second interossea comes and it gets inserted into the base of the proximal phalanx of the middle finger. Third interossea also comes from the adjacent sides of the third and fourth metacarpals and gets inserted into the base of the like middle phalanx, like of course the proximal phalanx of the middle finger. On which side? On the medial side. Towards the little finger is medial side and towards the thumb is lateral side. So second interossea is getting inserted on the lateral side. Third interossea is getting inserted on the medial side. The last interossea. Now you can write like it is coming from the adjacent sides of fourth and fifth metacarpal bones and gets inserted into the base of the proximal phalanx of ring finger. This is ring finger, okay, on the medial side. So all these dorsal interossea are responsible for this movement. This is abduction. Quite opposite to that, we have adduction movement, which is brought about by palmar interossea. Okay, just you have to, these are unipinnate muscles, not bipinnate. They are coming only from one side. Okay, again you have to start counting from the thumb side only. This is one. So first interossea, first palmar interossea is coming from the shaft of the which side? Now you should be very specific. Medial side of the second metacarpal bone. Insertion is base of the proximal phalanx. This is lateral side of the fourth metacarpal bone. Insertion is on the lateral side of the proximal phalanx of the ring finger. Okay, and this is the last finger. The lateral side of the shaft of the fifth metacarpal bone, and insertion is at the base of the proximal phalanx of the little finger. So like that, and palmar interossea are responsible for, palmar are for adduction, dorsal are for abduction. This is abduction and this is adduction. Okay, and all these interossea are supplied by ulnar nerve. Ulnar nerve. They are basically responsible for the mechanism of gripping. Okay, so these are the interossea muscles. Like retinaculum, recently I told you. You don't remember? Okay. PHST code I gave you. PH, what are the proximal bones and what are the distal bones we have?
Pisiform hamate.
Very good.
Trap- uh,
Scaphoid and trapezium.
uh,
Yeah, very good, very good. Okay, beta. Nice. See here, this retinaculum which you see in the front of the forearm, you call it as flexor retinaculum. Okay. Now towards the thumb side, we have ST is the code. We have scaphoid and trapezium bone. It is attached to scaphoid and trapezium. And towards the little finger side, we have pisiform and hamate. These are the two bones where it is taking its attachment. Okay, so this is the thickening of the deep fascia which is seen in front of the wrist joint. You will see few structures which are going deep to the retinaculum and few structures which are going superficial to the retinaculum, and it is given listed in your textbooks. And whatever muscles you see in the forearm, if you remember the names, what are the muscles we have? Palmaris longus, isn't it? Flexor carpe radialis, flexor carpe ulnaris, flexor digitorum profundus, flexor pollicis longus, isn't it? All these tendons, they are passing deep to the flexor retinaculum. Median nerve also passes deep to the retinaculum, but ulnar nerve passes superficial to the retinaculum. Okay, if there is any infection over here, you will see there may be carpal tunnel syndrome. Okay, that means median nerve may get compressed. Okay, and there may be claw hand. Okay, that is flexor retinaculum. Different pictures are shown. You can see exclusively bones only here. Okay, scaphoid and trapezium and pisiform and hamate. This attachment is flexor retinaculum. Okay, you have to know the attachments. You should know what are the structures passing deep to the retinaculum, what are the structures passing superficial to the retinaculum. Just see the list in your textbooks, and then you have to also see all exclusively tendons are shown which are passing deep to the retinaculum. Okay, different pictures are given. This is all flexor retinaculum. Which nerve is passing superficial? I said ulnar. Which nerve is
ulnar nerve.
going deep? Median. So if this is getting infected, you call that condition as carpal tunnel
Claw hand.
syndrome. No, carpal tunnel
Claw hand.
syndrome. Okay, it will lead to partial claw hand. 3.5 digits are supplied by median nerve. Lateral 3.5 digits. Okay, they will just bend like this. You call it as partial fly hand. Okay. Russia. Superficial and deep Pamaraj will take long time, but I will take tomorrow. I'll try to show you these two ganglions. See, for otic ganglion, Niharika, in parotid
Yes, ma'am.
gland, there is a photo of like flow chart of otic ganglion, beta. Can you please share it from textbook?
Yes, ma'am.
Chaurasia. There is a flow chart
Mm,
in parotid gland chapter.
yes, ma'am.
You please share that. You are supposed to write that. I will tell you. And for ciliary ganglion, I'll take you to the and so we have studied orbit, right? Inside the orbit, we have studied eyeball. We have seen extraocular muscles. If you remember, like superior orbital fissure, I have told you certain structures are passing inside. What were those? Trochlear nerve was going inside, oculomotor nerve was going inside, abducent nerve was going inside, ophthalmic division of trigeminal nerve also was going inside. So all these nerves, no, they form different components in this ciliary ganglion. Basically, ganglion is nothing but collection of cell bodies of neurons is called ciliary ganglion. So this is peripheral parasympathetic ganglion which is situated in the eyeball. Some of its components are coming from nasociliary nerve you see here. I'll explain you. Nasociliary nerve is a branch coming from ophthalmic division of trigeminal. Okay. And you will see one motor root is coming from the oculomotor nerve. That means oculomotor nerve is also giving twig. Nasociliary nerve is also giving twig. Even abducent nerve also gives twig. Okay. So all those nerves, they are actually relaying here. So that means these are preganglionic fibers. This is ganglion. From here, whatever nerves are coming, you call them as short ciliary nerves. See, short ciliary nerves, which are piercing the eyeball and supplying the ciliaris muscle. Ciliaris muscle, what we see, which will be constricting and dilating the pupil, that particular area surrounding the pupil, like controlling the pupil, we will have ciliaris muscle. So we are talking about this ganglion. Once you know about this ganglion, first you should have this ganglion in mind. Then I will tell you the theoretical aspects, what you are supposed to write. So this is good button. You can cite nucleus. Yeah. See, once you draw that rough picture, basically it may not come. So ciliary ganglion, where is it present? I hope you are seeing my shared PowerPoint, right? Shared screen. Yes. Okay. Ciliary ganglion, we just saw it was present inside the orbit. So it is seen like a fat between optic nerve and lateral rectus muscle. The nucleus it is connected to is Edinger-Westphal nucleus of oculomotor nerve. We did this nerve as essay question, third nerve, oculomotor nerve. So the preganglionic fibers are moving along through the nerve of inferior oblique, postganglionic fibers along short ciliary nerves. They go to like muscle fibers around pupil. You call them as sphincter pupillae muscles and ciliary muscles. Okay. This much information you write also, that is more than enough. Okay, beta. So are you ready with that, beta? Niharika?
No, ma'am, I did not
You
find it,
didn't
ma'am,
find?
in that.
Okay, okay.
Ah, no.
Parotid gland, there is one flow chart, no, beta? Nerve supply of parotid gland. Nerve supply, if you turn the pages under nerve supply, there is a flow chart, beta. If you
Okay,